Good afternoon, all. Thank you for joining us. My name is Dr. Leonard Jack Jr., and I'm glad to be here with you for today's webinar entitled Promising Innovations to Address Diabetes in Vulnerable Populations, Local Solutions with National Implications. For your background, I'm the Director of the Division of Community Health in the National Center for Chronic Disease Prevention and Health Promotion at the Centers for Disease Control and Prevention. I'm also co-editor of the Health Promotion Practice Supplement issue that our webinar will address today. I'm also proud to say I am a former National Advisory Board member for the Alliance. Today's webinar will highlight results from an evaluation of the Alliance programs. I'd like to thank the Alliance to Reduce Disparities in Diabetes for hosting today's webinar, and the Merck Foundation for sponsoring the discussion and for its support of the Alliance. I also like to recognize the Society for Public Health Education for co-hosting today's webinar, which highlights the Alliance work and outcomes published in the November 2014 supplemental issue of Health Promotion Practice. Health Promotion Practice is one of 3 peer-reviewed journals published by SOPHE devoted to the practical application of health promotion and education. There are 10 articles in the Health Promotion Practice supplement that encompass the work of all 5 Alliance sites, as well as the cross-site evaluation. Today's panelists are the authors of 3 of the manuscripts appearing in the supplement. Participants are encouraged to read the supplement, the November supplement of Health Promotion Practice. You can access the November supplement at http://hpp.sagepub.com. Before I introduce our panelists, I'd like to start by talking a bit more about the serious problem of type 2 diabetes in this country. Diabetes in the United States is a serious public health problem that disproportionately affects African Americans, Hispanics, Latinos, Asians, Pacific Islanders, American Indians, and Alaska Natives. In many cases, these groups have limited access to care and poor prospects for managing their illness. In order to achieve sustained improvements in diabetes-related outcomes, new strategies that go beyond individual or patient-level approaches are needed. These new strategies will require an intentional focus on policy, system, and environmental factors that contribute to health and well-being. Such strategies will also require a thorough understanding of the lived experience and the social-cultural context of populations and communities most affected by diabetes disparities. Local, on-the-ground experience and community engagement are critical to developing these innovative strategies and solutions. Since its launch in 2009, the Alliance to Reduce Disparities in Diabetes has supported, through funding from the Merck Foundation, the uptake of evidence-based and innovative practices to help reduce health disparities and inequities among populations in 5 communities: Camden, New Jersey, Chicago, Illinois, Dallas, Texas, Memphis, Tennessee, and the Wind River Reservation in Wyoming. Each project was implemented with an understanding that there are cultural norms, community characteristics, and healthcare system challenges that require sustained multi-component approaches to ameliorate factors that exacerbate poor disease management and health outcomes. Today, we will discuss the collaborative work of the Alliance that will offer guidance on what it takes to address the plethora of factors that systematically and systemically affect diabetes management in diverse communities across the United States. Closing the gap between services and support offered in clinics and communities across the 5 Alliance programs require a commitment of purpose and time, building coalitions that span the boundaries of those typically found in healthcare, establishing and nurturing trust, and sharing resources and data across clinic sites. In a few minutes, I will introduce our first panelist, who will tell you more about the work on the ground at one of these sites. Following the panelist presentations, there will be a group discussion followed by a Q&A session with the audience. To ask a question of the panel, you will type your question into the chat box that you will find at the bottom of your screen and hit enter. This will send your question to me and the panelists. You may submit a question at any time during this webinar. If your question isn't answered during today's broadcast, we will respond to you via email in the coming weeks. We are excited to get started with today's webinar, and therefore I am pleased to introduce our very first speaker, Dr. Monica Peak. Dr. Peak is an assistant professor of medicine and associate director at the Chicago Center for Diabetes Translational Research, located at the University of Chicago. Dr. Peak specializes in general internal medicine and preventive care healthcare for adults and has a particular interest in reducing health disparities. She concentrates these efforts on diabetes care and breast cancer screening education for African American patients. Dr. Peak will address how the integration of health systems and community partners is essential to improving the quality of health care and clinical outcomes in vulnerable populations. She will share key lessons learned and tips for effective use of the media to sustain these efforts. Welcome, Dr. Peak.
Thank you so much, Dr. Jack, for having me as part of this webinar. I'm really excited to be here, and like you said, I'm going to be talking about how we and our team, as one of the Alliance sites, integrated health system strengths as well as community approaches to try and be part of our portfolio to address diabetes disparities here on the south side of Chicago. Next slide, please. Great. So this is just a map that shows the city of Chicago, and you'll see in the southern part, which is southern part of the city, which is where our work is concentrated, there are higher death rates from diabetes in the city of Chicago, and the higher rates are corresponding to darker colors in blue. Next slide, please. So although we have a number of factors that are driving those disparities and challenges to communities, what we're trying to do as part of our work with the Alliance is to draw upon the actual strengths that we find in the communities and to find and collaborate with partners broadly defined. I'll talk more about that in just a second, to try and address some of the problems that we see. So we're trying to use an asset-based approach to reducing disparities here in the city. Next slide. So our work really is framed around the chronic care model, and we have 4 key elements. We do provider training. We have a lot of work to activate patients around diabetes care at home, as well as shared decision-making with their providers. And then with the top 2 bullets, you'll see community partnerships and quality improvement. And that's where we spend the time that I've been allotted today talking about those 2 elements, how we try to integrate them, but more particularly the lessons learned from that. So we have so much work that we're doing. The time constraints don't allow me to talk about all of the things that we do, but I will try and use a few key illustrative examples to talk about some of the lessons that we learned that are more broadly applicable to the audience here. Next slide. So this is a slide that just shows some of the kinds of organizations that we work with to establish our community footprint. So we work with both for-profit businesses, community organizations, community advocacy groups like the American Diabetes Association and the American Heart Association. We work with individual chefs and fitness instructors. Obviously, the faith-based community has a strong presence within the African-American community here in Chicago. And so we work with all of these to try and develop sustainable partnerships over time that will persist in the kind of work that we're trying to do and create. Next slide. So my first lesson, I would say, is to start small and then expand later. Rome wasn't built in a day, and neither will your project. And so I'll use the example of our food prescriptions to talk about how we started with one element and then added others to flesh out our program. Next slide. So as part of our work, we have prescriptions for both food and exercise that we use for people who have diabetes or don't. They're broadly implemented within all clinic populations with a special focus on people who have diabetes. And one of those is for the farmers market. So the food prescription program combines both the power of the physician recommendation. So you'll see on the slide that there is something that looks very similar to a physician prescription. And that's intentional to use the power of physician recommendation and prescription use to encourage people to make modifications in their diet. On the back of that prescription is a voucher or a coupon that's good for free fresh fruit and produce. And so for this one, we're highlighting the farmer's market. So people get $10 worth of free food at the farmer's market on the back of their physician prescription. Next slide, please. This prescription is actually stapled to a patient educational handout. So when a physician says, I recommend that you try and reduce the amount of carbohydrates that you're taking in, there's actually a list of foods that are low in carbs, as well as descriptions and definitions and guidelines. So people have a better sense of what of how the physician is making nutritional recommendations, and something that we tell people to put on your refrigerator at home as a constant reminder. Next slide. So we've had for a while, for probably about 2 years, these hard copy prescriptions that physicians could utilize within the clinic space. What we've done in the past 6 months is incorporate that into the electronic medical record as well. So in addition to people hand signing prescriptions, they can also, as part of their regular workflow, click on a button as they're writing orders for a chest x-ray or prescribing someone's blood pressure medicine or for a flu shot. As part of that same process, they can click on a button and write a prescription for a food prescription. So it becomes part of the more seamless workflow of physicians within the clinics themselves. And what they get is, as part of the after visit summary, the page you see on the right-hand side is a patient handout that talks about what the food prescription is. It has a picture of the prescription, both the hard copy and the one that may be generated as part of the EMR. And so on the left-hand side is what would print out in the printers that we use as clinicians for narcotics and for other things that can't be e-prescribed. So you can click the prescription, and then the narcotic prescription will print out. You click on the food prescription, and you get this automatic printout that comes. And so this helps our clinics meet their standards for meaningful use for the electronic medical record, and also provides just a more seamless and easy way for physicians in practice to incorporate the use of the food prescription within their workflow. Next slide, please. Well, we also expanded later. So again, we started the program about 2 years ago. Last year, we started doing educational tours at the actual farmers market themselves. So we trained more than 30 community members to provide educational tours so that people could, when they come to the farmers market, they can have sort of a warm, what we call a warm handoff. So there's someone who can go and introduce them to the farmers, who can talk about the kind of foods that are present for that season. The bottom right picture is our tent and our table that has our staff are always there doing surveys and collecting the food prescriptions and providing advice and counseling. And we also work with local chefs to do cooking demonstrations on the day of the farmers market. So every week when people come in to redeem their food prescriptions, they will also get an end experience that's positive and reinforcing for them about why they may have chosen to come, and hopefully that will encourage them to come back. Next slide. Our second lesson, I would say, would be the bullet number 2, which is identify champions. All organizations are made up of people, and really finding a person who's passionate about the work that you're doing and having them be the champion of your cause internal to their organization makes a huge difference. So that's a lesson that we can all understand and all relate to, so I didn't have any examples for that. But I would say identify champions when you're working with organizations. The third lesson learned, I would say, is find projects that are of mutual benefit. That's really going to be key to sustainability, is not just that it's good for you and your organization and your patients that you're interested in, but it's also equally important to organizations that you're working with. Next slide, please. So this is a picture of a community group, a community organization, the Clio Community Family Life Center that we work with the first Wednesday of every month, meaning that we were there yesterday. And they give out several tons of food that's high in quality, always has fresh produce. It's stocked by the Greater Chicago Food Depository. And so they have been doing the food pantry for about 3 years. Next slide. For the past 2 years, we've been partnering with them in ways that are mutually beneficial. So for our team, we have patient empowerment classes where we really sort of ramp up people's notch of their stages of change and a willingness to engage in lifestyle behaviors that are healthy. And so what we wanted to make sure that we did was to identify and collaborate with community resources that were sustainable. So when people decide that they want to eat more healthy, then here's the resource that's right here in your neighborhood you can come to every month and stock up on all the vegetables and fruit that you need and other things to help your family cook healthy for the rest of the month. Clio, on the other hand, was functioning as a distribution site for the Greater Chicago Food Depository, but other than the food distribution itself, they didn't have additional resources that they wanted to have as part of their program. They didn't have health education, other health resources, screening for diabetes or hypertension, other health professionals there to field questions, and so that's what we brought to the table. So we were able to think about the resources that we already had in our respective organizations and map that to what we actually needed and come together to have a partnership that's been fruitful, and has expanded and has been very well sustained for the past several years. Next slide. So this slide just has two pictures. One is of the Clio Center on the inside where we do our health education. The other on the right-hand side is a picture of some of the food that we're doing for preparation as part of our food cooking healthy demonstrations for the food that is distributed at the food pantry that day. The fourth bullet says, align with organizational strategic priorities. And so all of the work that we do, we're housed at the University of Chicago. So we certainly are making significant collaborations outside of the walls of the university and the medical centers and the clinics that we work with. But we do have our research home base at the university. Next slide. And so what we've done is work with other researchers like Dr. Stacy Lindow, she showed at the right, Dr. Dorian Miller, she's shown on the left, that are part of the university and doing similar work and fitting into part of the dean's larger umbrella initiative and priorities for how the institution is engaging with urban health. So we've worked specifically with the institution's urban health initiative. The University Medical Center has had particular collaborations that helped make our work possible. So when we were first getting started 6 years ago, we partnered with federally qualified health centers that the university already had established relationships with. We already had faculty that were seeing patients at that site. There are other kinds of collaborations that were happening that made it an easy entree for us to be able to work with those organizations. One of the part of our work that we think is central is finding medical homes for people that we engage in the community who don't otherwise have that. And we work in partnership with the Southside Health Collaborative to be able to find medical homes for people that we may see at a health fair or in any number of our community events. So that is a collaborative work that we do that fits as part of the institution's larger initiative of how we're engaging issues of community benefit and access to care. I had mentioned the food prescriptions just a few slides ago, and so now in addition to physicians having the option of writing a prescription, of e-prescribing it themselves through the electronic medical record, it's now part of a broader initiative called Healthy ERX, which takes a patient's geographic information for their street address and their zip code, and also uses their clinical ICD-9 codes to automatically generate resources that are close to their home that may be relevant for them. So even if a physician doesn't remember to e-prescribe a food prescription, it still gets automatically printed as part of the after visit summary, albeit in a much smaller space, but it still gets to the patient. So we now have 3 mechanisms through which we are organizing with the university's infrastructure and with other researchers to make sure that our message is getting across and we're having as many touch points with patients as possible. Next slide. I showed you in the map initially that it was one of diabetes mortality in the city, and we've been working with the city's public health department to create similar maps utilizing state hospital data to identify hotspots or areas of disproportionate concentration of diabetes-related hospitalizations that are avoidable. So it helps us think about how to target resources, particularly for high-cost things like hospitalizations. And so that's a priority for our team, our diabetes team on campus, but it's also a priority for the health department. And so we're able to use some of our research resources to combine with the health department's priority about how they're developing their strategic plan for diabetes and come together and create some of these maps which have practical utility both for research and for implementation. Next slide. And the last principle or lesson learned that I would say was utilize the principles of community-based participatory research or community-engaged research when you're partnering with organizations outside of the health system. Next slide. So even if you are not engaging in a research project itself, any kind of program really requires that you have an approach with working with community organizations that is equal, and this one, I'm sorry, is going to have bullets on it, so if you can, thank you. So first remember that it's about people. Again, all organizations are made up of individuals and people, so work to establish relationships with people first, and then think about what your common interests are. Start with your friends. Those are always easy, or like-minded organizations. Again, thinking about what is your strategic vision, what is your mission, what are areas of mutual benefit that you can start with, what are easy wins, low-hanging fruit to begin your work. Next slide. Next bullet, build relationships before organizations. So people switch jobs, grants come and go, but having a solid sense of community and collaboration with individuals as well as with the individual organizations makes your work exponentially easier, so that when people relocate, they're still part of the work that you're involved in. They give before you get. Next. Nurture equal relationships. So these are all things that we learned in kindergarten, but that it's important for us to remember as we're engaging with organizations. Next, 2 bullets. Great. So the last one I had mentioned before. The first is particularly relevant for cities like Chicago, which have a long historical and fruitful legacy that arises from our history, our policy, our economic context. Really, it's important to understand that when you're going in. We've been able to leverage what we've learned and capitalize on this information to make our work better and stronger. I think there's one last bullet. Yes, do good work and good people will find you. So we found that we have been able to enhance the scope of our work, both in terms of depth and breadth, because of the large number of volunteers that have come to our program, the people who have just found us, both students, faculty, community groups, clinicians in the community. And so I would say, and I would encourage everyone to keep your eye on the prize, do the good work you're supposed to do, and it will be made easier by people finding you as well. And with that, I just want to go to the next slide and acknowledge my project team, particularly my co-PI, Dr. Marshall Chen. Next slide. And acknowledge our funders, particularly the Merck Foundation. Thanks so much.
Thank you, Dr. Peak, for that wonderful presentation. Next, we will be joined by Martha Quinn. Martha is a Senior Policy Research Specialist at the Center for Managing Chronic Disease, located at the University of Michigan. Monica has worked in health policy at both the federal level, working as a congressional staffer in both the U.S. House and Senate, and at the local level for a children's health policy advocacy group in Chicago. At the Center for Managing Chronic Disease, Martha has focused on the evaluation of system and policy change interventions. Martha will address how Alliance partners evolve their work from program delivery to policy and system change in order to overcome barriers and support implementation and long-term sustainability of their health system changes. Welcome, Martha.
Thank you, Dr. Jack. So I am going to talk today with you about the policy and systems changes that the Alliance sites have been able to implement over the 5 years of the initiative. And it's important to start out by pointing out that the Alliance was really not conceived of as a policy change initiative, but really rather as a way to implement effective diabetes programs and services. And so this slide includes the stated mission of the Alliance since the very beginning of the initiative. And the mission has focused and continues to focus on reducing disparities and enhancing quality of care. And I underlined the word programs in this slide because programs were really explicitly targeted in the beginning of the initiative. However, as the partners began to evolve in their work, and I added a more recent slide that we're using here, there really was a shift from program delivery to policy and systems change. And this shift occurred in part to overcome barriers in their work and in part to really enhance the sustainability of their work. So as the work evolved, the mission evolved and really kind of has two main components. The first on the left here is this idea of focusing on community level change. And then secondarily on the right hand side really looking at care enhancing policies. And the NPO started seeing evidence of this shift pretty quickly into the initiative and realized that it would be important to be able to capture these changes. So in 2010, the NPO created an assessment team to look at ways to capture and track these policy and systems changes. And some of the methods that we used included looking at site reports and really strategically trying to pick out the specific system and policy change efforts that were underway at each site. And next we conducted telephone interviews with people at the sites and had kind of informal discussions at grantee meetings and that sort of thing. And lastly, we implemented a pretty comprehensive verification process, which included several emails and calls with individuals from the sites to really understand what these efforts included and to make sure that we were capturing everything going on. So what was generated from these tables and from this process really was a set of tables, one table for each Alliance site, which listed each significant policy and systems change underway. And this slide is an example of the Camden table that we had created. And one of the important things to start off was to really define criteria for what constitutes a policy or systems change. And so we defined policies as adoption of new policies or written procedures or changes to existing policies. And these could be either organizational policies or public policies. And we defined systems changes as changes in practices and norms in one or more components of a health system. And examples of this might include building electronic health registries or establishing new office visit structures such as group visits. We did not include, specifically did not include new programs, events, activities, that sort of thing, because we were really trying to look through this lens of sustainability and trying to capture changes that would live on past the funding period. So aside from capturing the description of these efforts on these tables, we asked the sites to try to describe the level of change of where these efforts were. And this ranged from statewide to community-wide and organization-wide as well. We also asked the sites to help us understand the stage that the change was at. And this ranged, again, from a ranking of 1, which was in the very beginning and development stage, to number 4, which was that the change had been adopted, implemented, and was now being maintained currently. So these different stages really allowed us to be able to track progress over time and see how things are changing. We also asked the leaders to document how these changes were written down. In some cases this was in a clinic handbook of procedures, maybe business agreements and that sort of thing. And finally we asked the site leaders, which was a harder one, to try to estimate the potential impact of how many people would be affected if this change was implemented. So from these different tables, we were able to look across all the data that was coming from the 5 sites and see what efforts were really most common across these sites. And we went through this process of categorizing the different efforts into some main categories, and that's what you're going to see on this slide. And I apologize if the text is a little bit small. But some of the main categories that we were able to come up with were changes related to community health workers, changes related to comprehensive health information systems, implementing diabetes self-management education, and clinic redesign and provider education changes. So when we created these kind of larger categories, we also needed to create some smaller subcategories, which you can see are listed directly below the larger categories. And so this, for example, gave us a way to really better understand what the change had been. So for example, if you look under community health workers on this slide, you can see that securing reimbursement for community health workers services was an effort that was common in 4 of the 5 Alliance sites. And again, this gave us a way to look across all of the different sites and see what was happening. So we also looked across the tables to try to get a better understanding of the stage of accomplishment across these various efforts and the level of scope of the change. So if you look at the slide here, there were a total of 53 individual changes or efforts that we were tracking. And when you look at the bar graph, you can see that the majority of these efforts were already in the implementation stage. And if you look at the scope of change diagram there, you can see that the majority of these efforts were at the multi-organizational level, which meant that they were being implemented in more than one organization, but not yet at a citywide or a statewide basis. So again, the majority of these efforts were brought to the implementation stage, which is a pretty far advanced stage, and were in the kind of multi-organizational local category. So now I want to turn to just a few kind of exciting examples that were generated from the Alliance sites. And I'm going to start with the Alliance team in Dallas. And they were able to successfully institutionalize the role of community health workers within their health system. And this effort really started when one member of the Camden team drafted a pretty narrow job description, really, for a diabetes educator for one of the projects. And so she started small with a pretty narrow description, and then after meeting with other people from their health system, realized that there was a larger need for community health workers, and not just in diabetes, but across other projects. And so she really joined forces with others and found a champion, some of the things that Monica was just talking about. And the champion here was this director of social work at the health system. And so together they really worked to create a comprehensive, broad-based job code for community health workers that was eventually institutionalized across the whole health system. And the Dallas Coalition also was able to locate funding to support their community health worker positions through a Medicaid innovation waiver called Medicaid Waiver 1115. The strategies that worked well for them really included this idea of starting small and scaling up, finding a champion that had both the passion and the power to make the change happen, and then being able to find a funding stream in order to sustain the positions. So another good example was in Camden, and this was with the establishment of the Camden Health Information Exchange. And this is an electronic database that allows for the sharing of patient health information primarily between hospitals, physician practices, labs, and other healthcare organizations. And some of the strategies, well, actually the main strategy that worked so well for them was this idea of building trusting relationships among and between these providers, specifically hospitals and other providers. And in fact, one of the people from Camden referred to this health information exchange as really the circle of trust. Another strategy was here to start small with just a few providers and then to scale up to a citywide exchange. And it's important to point out that specific policies and system changes needed to be in place in order to make all this happen, including establishing some written and binding business agreements, implementing electronic health records, and building diabetes registries. So lastly, I want to talk a little bit about the Wind River example. The Wind River Reservation was successful in creating a coalition of partners from tribal health programs, Indian Health Services, the state of Wyoming, and they all helped to establish a system to identify high-risk patients and refer them to diabetes self-management education. And it was through this streamlined and really standardized process that they were able to increase referrals to their DSME programs. They also have been able to secure reimbursement for DSME classes through various funding streams, Medicaid, Medicare, as well as private tribal insurance. So in conclusion, when looking across some of the most successful work to date from the Alliance sites, we were able to identify some essential elements that help to facilitate sustainability. And Monica has already talked about some of these that she found, or that they found in Chicago. So I will skip over a first few there. But some of the other ones, aside from starting small and scaling up and building trust and finding champions, is this idea of using data to support the change. And many of the sites found that it was really helpful to always have evidence of effectiveness and improvements in patients' outcomes to support their change when they're kind of making this case to the decision makers. Identifying common goals was another thing, and mutual benefits that Monica had talked about. But also the recognition that it takes time to bring about these long-lasting changes and to be able to allow that time and to put in the foundational work first to do that. Documenting change was another thing that we saw that was really critical, and in fact it almost became kind of a litmus test on our tables. That the sites really had to be able to document where this change was written down. And in some cases, if there was no place that it was a documented change, then maybe it really wasn't a sustainable kind of policy and systems change. And lastly, just this idea of locating additional funding and resources in a way to be able to really move these efforts along. Thank you.
Thank you, Martha Quinn, for that informative presentation. Our last speaker today is Dr. Megan Lewis, a senior research scientist at RTI International. Dr. Lewis has more than 20 years of experience in both quantitative and qualitative research. She has unique expertise in health-related interpersonal communication, and her work has been published in leading journals. Her research has been funded by the National Cancer Institute and the National Institute of Arthritis and Musculoskeletal Diseases, among others. Dr. Lewis will share how the Alliance programs utilize the chronic care model to create improvements in clinical and patient-related outcomes. She also will present key findings from the cross-site evaluation in the areas of clinical outcomes, self-care behaviors, and disparities reductions. Welcome, Dr. Lewis.
Thank you, Dr. Jack. It's a pleasure to be with everyone today and be a part of this webinar and to be able to share some of the really exciting effects that the Alliance had overall. So as mentioned earlier, I'm with RTI International, which is a not-for-profit research institute, and our role in the Alliance was to conduct an independent evaluation of the Alliance programs as a whole. So we've heard about some specific examples and specific sites, but our job was really to look across particular interventions, grantees, and populations, and look at the contribution that the Alliance made across these different grantee programs. So today I'm going to focus on some of our findings from the cross-site evaluation and really just a snippet of some of those findings because as was mentioned earlier by some of the other speakers, there was a very comprehensive evaluation that was conducted of the Alliance initiative. And we really wanted to focus on answering the questions, did the Alliance programs lead to changes in important clinical indicators that are important for diabetes, such as hemoglobin A1C and blood pressure, and did the Alliance programs enhance patient-reported outcomes, such as self-management behaviors that are key to diabetes management? Next slide. So as part of the cross-site evaluation, we engaged with the Foundation and the National Program Office and the grantees over a 5-year period in which we collaborated to define the scope and the measures that would be included as outcomes. And that collaboration occurred in the first year, and we came to an agreement about the kinds of measures that would be important to include, when they would be measured, and so on. We also collected both these quantitative data measures, such as clinical outcomes and patient-reported outcomes, and we conducted a comprehensive qualitative process evaluation. And that process evaluation really aimed at understanding important implementation processes that could inform future multi-level, multi-component initiatives like the Alliance. And as was mentioned by Martha, we looked at documents and we had grantee site visits, and so we took a very kind of comprehensive, in-depth approach, really focusing on implementation because many of the sites were very active in implementing these programs when our process evaluation was taking place. We also did a cost-effectiveness modeling, and I'm not going to go into that in much depth today due to the time. Next slide. So the conceptual perspective that guided the Alliance as a whole was an adaptation of the chronic care model. And we emphasized its potential for diabetes specifically, and we're curious if it could be applied in an initiative like the Alliance, in which grantee programs all implemented very complex multi-level, multi-component programs that focused on these health system changes, examples of which you've already heard some of, engaging community partners. You've already heard some examples of those as well. And they also focus on enhancing cultural competency and communication skills in healthcare providers and implementing interventions that supported healthcare teams. They also focused on empowering patients via self-management education, while also using an implementation strategy in many of these sites that was very unique to their local needs, built on local strengths and resources. So the implementation strategy was not exactly the same in each site, although they focused on some common elements. Therefore, we concluded if we could find significant changes in the outcomes and common implementation processes that were important across the sites, it would suggest that this model could be used to guide implementation on a larger scale, while also allowing programs to tailor interventions to their local needs. So as the next slide illustrates, this model, the chronic care model, next slide, was brought to life in the programs. So this is the Alliance model that was developed by Noreen Clark and some of the grantees in a 2011 publication. And so the grantees really made the programs come to life in ways that met each community and prioritized the needs for the most vulnerable community members. So they took the chronic care model and they basically said, how's this going to work in the process of the Alliance programs? So they focused on engaging community members and community organizations, empowering patients, implementing state-of-the-art provider education, and focusing on sustainability right from the start. And so all these different kinds of examples that are provided as part of this Alliance model are what became kind of the foundation of the Alliance program. So what did our evaluation find? Next slide. We found that clinical outcomes improved across all the sites. So when we compared program participants to a comparison group over time, we found that hemoglobin A1C decreased in both groups, but decreased more in program participants. Program participants experienced significant decreases in both systolic and diastolic blood pressure, while the comparison group only experienced changes in diastolic blood pressure. Both had significant changes in cholesterol, and the program participants had significant decreases in triglycerides, but the comparison group did not. Next slide. We also examined for program participants if improvements in A1C depended on the number of self-management classes they attended, which it did. Those who attended all the classes had better outcomes than those who did not attend all the classes. Next slide. We also measured very important diabetes self-care behaviors that are really critical for the day-to-day management of diabetes for people who are managing the disease. And we found that for program participants, all of these kinds of self-care practices improved over time with the exception of smoking status. So this was an important indicator that not only were clinical outcomes changing, but also important self-care behaviors for the diabetes management was changing as well. And I'm not showing the numbers for the other changes that we looked at. Those are in our publication. But we measured other patient-reported outcomes as well, such as quality of life, diabetes competence, and resources and supports for self-management, which is a measure of healthcare quality perceptions. And all of these improved over time as well. Next slide. And we found that these perceptions of healthcare quality were important for hemoglobin A1C. So these perceptions were an important intervening variable. So those with greater perceptions of healthcare quality, as measured by our resources and support for self-management measure, had greater decreases in hemoglobin A1C over time. So this was an important finding for us because it was like a measure of healthcare quality that we found that was changing the effects of on hemoglobin A1C over time. Next slide. We also looked at the percent of patients and the comparison group members who met healthcare quality indicators for our clinical outcomes. So we found that for A1C and blood pressure, a greater percent of program participants were in better control compared to the comparison group. And these were important findings as well because what it indicated that as time progressed, more program participants and more percentage of program participants over time were meeting quality standards, and these quality standards are important for things like reimbursement and other kinds of quality improvement processes in the clinics that were implementing these programs. We didn't find any change for cholesterol over time as well, and we attribute that really to not having enough measures of cholesterol, and so we had less power for those analyses. And I'm not going to present the findings specifically about cost effectiveness, but we did find that the programs were cost effective. And it's like many interventions that are complex, the multi-component and multi-level, it doesn't mean there's a kind of dollar for dollar return, but it means that you get good value when you spend this kind of money in terms of the net benefits over time. And so in our cost effectiveness modeling, we projected that there would be fewer adverse events over time and higher quality of life. Next slide. So in addition to the quantitative findings that indicated that there were important clinical improvements across the Alliance as a whole, we also did a comprehensive qualitative process evaluation, really to focus on the implementation processes that might be important, and these themes that emerge could help provide guidance for other multi-level, multi-component interventions seeking similar changes. We focused on many different aspects in the qualitative process evaluation. In the special issue, we focus and provide some information on the patient self-management component of the program, and there we found 4 themes to be very important. One was the empowerment of patients and implementing processes where patients felt empowered to take control of their health. We found that increasing access to self-management programs was extremely important. We found that support, not only from the healthcare team, but from family members as well, was an important process for patient self-management. And addressing local needs and barriers was a really important theme as well, as was care coordination. So all these particular processes were put in place in site related to patient self-management that made the program successful. We also looked at the implementation of the healthcare provider training and the formation of multidisciplinary teams for healthcare, and found some important themes as well. So communication and cultural competency training for providers was key across many of the sites. And not only was it just cultural competency training, so that providers felt more efficacious in communicating and talking with patients of different backgrounds, but the communication training as well was very important as well. Is that how do you bring patients and providers together so that they have meaningful dialogues at the point of care? That was an important aspect of how healthcare teams and providers were supported in these interventions. And because of that, providers became very good at engaging with patients and talking with them. And again here, care coordination became a really important theme when we looked at these multidisciplinary teams. There was a lot of focus on how care was coordinated for particular patients across different disciplines, across different work lines in the clinics. And so care coordination is emerging as a very important theme across many of the sites and across many of the different components. We also looked at just the fact of how they implemented these multi-level, multi-component programs, and kind of taking a broader view. And we found here that communication was very important. And this, I think, is reflected in some of the comments that Dr. Peek made originally, is that there has to be very systematic processes put in place when you're implementing a complex, multi-level, multi-component program, so that there's clear and regular communication with partners, with community stakeholders, outside of the organizations. Inside the organizations, there has to be very clear and systematic communication about program implementation and changes and things like this. So communication is a very important theme. Relationship building was another very important theme across all of the sites, and I think that's come across in some of the other presentations as well. And another theme that came out when we looked at how they were coordinating these complex programs is alignment. Alignment with programs with the larger organizational and community values and institutions in which these programs were taking place was very, very important. And I think a good example of that, as you can see, is in Dr. Peek's presentation, is that these programs became very embedded in the organizations and the communities in which they were taking place. And they did that by making sure that their programs were aligned with the values and the norms of the institutions in which they were taking place. And as Martha talked about, sustainability was an important theme as well. From the start, programs were starting to look forward to the future, trying to secure funds, but also here care coordination became a really important aspect of sustainability, because once you put these systems and communication systems and care coordination processes in place, it's likely that these kinds of things will continue over time. So clinical and community collaborations were one way that they tried to foster coordination and teams, sustainability, the use of community health workers as a way to, when you broaden the workload, as a way to community health workers were used to not only get patients to the clinics, but then also providing kinds of education to patients before they saw their healthcare providers, so that those encounters could be more meaningful and efficient when they were patients and providers were together. And sharing electronic data, Martha talked about that in the Camden site, but sharing electronic data also happened within organizations as well. And so that sharing of information became a really important theme in terms of how these programs could be sustained over time. So these processes and collaborations became embedded in many of the sites. Next slide. So based on a variety of different areas of evidence, not just one particular set of analysis, we concluded that the Alliance programs did reduce disparities and healthcare disparities for the underserved program participants that they were serving. They improved important clinical outcomes that are indicators of diabetes and diabetes control. They reduced a gap when we looked at our comparison group. And we talk about in the paper about how some of our findings of the Alliance as a whole compare to other kinds of interventions. Patient outcomes indicative of better healthcare quality improved over time. Important patient-reported outcomes related to diabetes self-management also improved over time. And we also identified important implementation processes and themes that could help speed translation for other kinds of programs that are seeking to implement these kinds of changes. Next slide. So in conclusion, a longer evaluation might be needed to detect some further reductions in disparities or changes in some clinical outcomes that we weren't able to find, for example, in cholesterol. Cost effectiveness is how we looked at the cost benefit and the cost benefit ratio in these analyses, but we didn't look specifically at healthcare cost utilizations, which is something that would be a contribution as well for future projects. And the essential components here that we found are many of the themes that you've heard from the previous presenters, is that these multi-level, multi-component interventions have to target key determinants for change, whether that's in the patient population and empowering them with knowledge and skills, whether that's providing healthcare teams and providers with the skills that they need to communicate effectively, and providing the systems so that they can coordinate care. You need strong leaders and champions, and it's interesting. This has come up again and again and again. And sometimes people poo-poo. We already know that champions are important, but you just really can't ignore that. Champions, they sustain programs when there's delays. They keep people's motivation up, and so you really need them. We found that patient empowerment is really key for self-management. That you have to have implementation of systems and interventions that really support the patient-provider interactions, so that those care meetings between the patient and provider are effective. And there has to be alignment and care coordination of these programs and sustainability that's planned from the beginning. I think that's the end. Thank you.
Thank you, Dr. Lewis. It's always very relevant and important to talk about the insights from the contributions across each of the Alliance projects and how they contribute to factors that promote system change and, more importantly, improve clinical outcomes. A big thank you to all of the panelists for their engaging and insightful, informative presentations today. Now I would like to engage the panel in a few questions based on what you've heard today during the webinar. I would like to go to Martha Quinn. Question we have here is, are there stages of accomplishment following a theoretical model? Are there stages of accomplishments following a theoretical model from our audience?
From our audience, sure. Yes, the stages of accomplishment was something that we put together with Dr. Noreen Clark a few years back, and we did try to follow a model, and I can get the person who is asking the question the exact information as to where the model is found. But the whole idea really was to be able to track progress along the route and to be able to have some key indicators as to what is in one stage compared to another stage and et cetera on. But I'd be happy to follow up and give the exact model and that sort of thing.
Okay, thank you. Dr. Peek, Can you provide more details on the chronic care model? It's been published widely, but one of the participants on the webinar today would like for you to just give a little bit more detail about the chronic care model.
Sure. So you're right. It's a model that has been around for a while, so it's not new, but unfortunately a lot of clinical practice isn't adhering to that still today. And it really just is the idea that we would organize a health system around patients. So more current terminology about patient-centered care, I think, also align with the chronic care model. It also recognizes that patients don't live in our health system, that they're people who live in their community, and it really calls upon us as a medical system to partner with and acknowledge things that are in the community that help our patients when they go back to being regular quote-unquote people in community settings. So it calls for patients to be activated, for our health systems to really be organized well as far as having electronic records, using registries to identify high-risk patients, to have a proactive healthcare team that really engages their patients and is up on standards of care and is excited to be at their job. And so really, it's really what we would all want to have as an experience for managing our diseases when we go into a healthcare system. It's particularly relevant for people with chronic diseases because this is something you have to think about every day. It's not just taking penicillin for strep throat. It's something that requires patients to engage at home, in their communities, and with the health system on a regular basis. So it's really a model sort of thinking about all of the factors that promote good health outcomes and how can we as a health system try and create a system that optimizes that.
Mm-hmm. Well, here's a question for each of the panel members, and we'll start with Dr. Lewis first. What aspects of the Alliance programs do you feel are most applicable to other organizations and programs? So each of you have presented wonderful information, and just wondering if you could reflect based on what you presented and your experience around your respective Alliance programs, what you feel are most applicable to other organizations and program lessons learned. Dr. Lewis,
okay.
can you?
Yeah. Yes. Well, it's. I think there's not one simple answer, and as Monica just mentioned, the chronic care model acknowledges that people don't live in healthcare systems and is especially useful for chronic disease management. Managing chronic diseases can be a very complex endeavor for patients. And so I think what's useful for other organizations and other kinds of initiatives that are trying to manage chronic illness or multiple chronic illnesses, which is probably occurring as well, is that these initiatives need to be multi-component. They need to focus on different types of levels of analysis and intervention determinants that they're trying to change. So you can't just focus on increasing patient knowledge or just focusing on how do you get a community stakeholder to be involved in your program. These chronic illnesses are multifactorial in terms of why they're problems to begin with, and the solutions have to be multifactorial as well.
Okay, I know I asked all the panelists to give some thought to that. What we will probably do is have you all follow up in a written response that we can share with all the with all of our participants, because we are tight on time. So again, I want to thank all the presenters for their outstanding presentations today. As you have heard today, we are making strides in reducing healthcare disparities, but there's certainly more work to be done. Integrating healthcare and community approaches are critical in order to empower and reach patients where they live, learn, and work. By educating patients and providing them with the tools that they need to access healthy foods, exercising safely, and managing their diabetes, we can strengthen the patient-provider relationship and ultimately improve health outcomes. Long-term systems and policy changes, including incorporating community health workers into the clinical care team, developing peer education networks, encouraging electronic patient data exchange, and embracing the Affordable Care Organization model are all ways to ensure our most promising solutions for reducing healthcare inequities that are occurring. While continued research and longer evaluation periods are needed, to see significant improvements in clinical outcomes and to identify underlying causes of disparities, lessons learned from the Alliance have national application for other chronic diseases. By focusing on community collaboration, care coordination, patient empowerment, and eliminating cultural barriers to quality health care, we can successfully address healthcare disparities and inequities in other communities across the country. If you'd like to access a recording of today's webinar or the slides, they will be available on the Alliance's website at allianceforddiabetes.org in a few days. I will encourage you also to share the recording with your colleagues. You can submit any other questions via the Contact Us feature on the Alliance's website. Again, we encourage you to read the November supplement of Health Promotion Practice. The Society for Public Health Education is also offering a podcast with Health Promotion Practice Supplement co-guest editor Tawara Good, Director of the National Center for Cultural Competence and Associate Director of the Georgetown University Center for Child and Human Development. You can read the supplement and listen to the podcast by visiting the link shown on the current slide. If you are a certified health education specialist or a master's certified health education specialist and would like information on receiving continuing education credit for this webinar, please visit SOPHE's Center for Online Resources and Education at www.sophe, that's SOPHE.org/education.cfm. Finally, if you're in Washington, D.C. on Thursday, November the 20th, we invite you to attend a briefing hosted by the Alliance titled Uniting Policy, Practice, and System Change to Create Healthcare Systems That Work. This briefing will be held from noon to 2:15 p.m. Eastern Standard Time at the National Press Club. For more information or to RSVP, please contact Melissa Warren by emailing her at mwarren, that's MWARREN, at ccapr.com. Again, on behalf of the Alliance to Reduce Disparities in Diabetes, the Society for Public Health Education, and all of our presenters, thank you for participating and joining us today for today's webinar. Have a great remaining day, everyone. Thank you.